Hello, everyone. My name's Derek, and today I'm going to be talking about the use and positioning for handheld dynamometry. So just to begin, I just wanted to talk about just muscle strength in general. So what does muscle strength tell us in PT? So it has been known as a predictor of function, mobility, independence, and things such as activities of daily living. Manual muscle test gradings also give us judgment on a patient's diagnosis, prognosis, and plan of care or treatment. And generally speaking, manual muscle grades allow us to objectively measure progress over time with the patient. So let's take a look at the evolution of measuring strength throughout the period of physical therapy. So it initially started off in 1912 with Wilhelm Wright and Robert Lovett, and they developed manual muscle testing for the treatment of polio. And it originally started off with just three gradings. So normal, partially paralyzed, and wholly paralyzed. And then over the course of a few decades, it then evolved from Lohmann in 1927 on a 0 to 4 scale. And then they started adding in plus or minuses for intermediate strengths. And then in 1932, the 0 to 5 scale was introduced. And then the plus or minuses were given to all grades except for 0 to 1. And then we have in 1936, Henry and Florence Kendall. They really delved into understanding and documenting the different methodology for positions and the way to actually conduct the manual muscle tests and how to position the joints. And they documented that very thoroughly and were able to hand it out to all the army hospitals in the United States. And then in 1946, we had Daniels, Williams, and Worthingham, and they created a comprehensive text on the manual muscle test similar to Kendall, but at the time, the Kendalls weren't as published. But in 1946, they created concise and simple testing methods, which then became known as the Daniels and Worthingham's muscle testing. But then after that was produced throughout a period of 6 decades or so, in 1946 to 1993, we had the Kendall saga, as it's known as. And this is when there is extensive muscle testing and publishing on manual muscle tests. We've seen Kendall's 0 through 100 scale, and then we returned back to the 0 to 10 scale in 1993, which uses pluses or minuses all the way up, starting after 1. So throughout the period of time, the use of manual muscle testing more modernly has been under some criticism, uh, just in different within different populations. So when we look at what manual muscle testing was initially developed for, it was initially developed for more neurological conditions such as polio, spinal cord injury, multiple sclerosis, peripheral nerve injury, impairment status post-stroke. But however, we do also see it utilized in tendon muscle injury in post-surgical patients. But the criticism from manual muscle testing comes from the subjectiveness of the test. And so the thing about conducting manual muscle testing, as we all know, is the amount of force that we're applying individually may differ between different clinicians. And so I might be pushing differently than Cody on a person's shoulder flexion. And so that just could give us different readings, especially when utilizing that 10-point scale and just the subjectivity of assessing a patient's expected strength. So just looking at that patient, I then have this preconceived notion of how strong that patient should be, kind of based on their physical stature and what they're coming in for. Another thing about the subjectiveness of manual muscle testing is after grade 3, after we get through the gravity related aspects of the manual muscle test grading, everything from there turns into subjectiveness, turns into my own interpretation of how hard I'm pushing and how much force that patient is able to resist. And so the lack of sensitivity within grades 3 through 5 has just been under criticism because we can't for certain say that it is truly objective. And then another thing about the gradings between manual muscle testing is it's on an ordinal scale, that just meaning the difference in force production from 3 to 4 isn't as equivalent as it is from 4 to 5. And so the differences between the numerical values that we grade the patients on their strength isn't necessarily equivalent between numerical values. And so we found in the literature in 1980, Serenity et al. Reported early electromechanical devices that were utilized to quantify muscular force. And so we'll take a look at that. So here we have 3 different electromechanical devices pictured here on the left. So everyone's familiar with like a hand grip handheld dynamometer. So that's kind of what's pictured here on the left, but that's a much cheaper version of it. Not as similar to the ones that the OTs use where they're just going into finger flexion and gripping. We also see the crane scale. So this is kind of what you use if you've ever weighed your own luggage, just lifting it up. The tension that is being pulled on the device then gives you a force output. And so they do have these that are available to use in terms of measuring muscle strength within patients. But today we're going to be more focused on the handheld dynamometer here pictured on the right in those 3 pictures. And so the handheld dynamometer is a portable device, and we'll kind of go into more of that. But just to kind of reference those 3 pictures that are on that left side here, what we have pictured on the right is the isokinetic machine. So this is our gold standard. This is what's most utilized in the research when measuring a patient's true strength. The only con, as you can see here, is the amount of money that this costs. So ranging anywhere from $50,000 plus, and it's not as portable as those devices here on the left. So it does have to be anchored down into the ground. And a lot of the times there's a limited amount of muscle positionings that you can actually utilize within that anchor there. So usually here you can pretty limited to lower extremity testing, knee extension, knee flexion, and maybe some hip abduction and extension with that device. But let's talk more about handheld dynamometry. So when utilizing a handheld dynamometer, uh, there's 2 different ways you can use the device, just like there's 2 different ways that you can measure someone's strength just using your hands for manual muscle testing. And so we have the make test and the break test. And so for the make test, clinicians instructing patients to go ahead and push as hard as they can into the device for about 3 seconds. And then after that, you'll have them relax. And that's usually ran within the literature 3 to 4 seconds. But on average, I'd say I'd seen it more 3 seconds in total to generate that peak maximal force. And then just generally speaking, with these different make and break tests, the patient will usually have at least 2 trials of that same action. So for instance, if I'm measuring a patient's shoulder flexion, I would first trial that once, trial that twice, trial that 3 times, and then take the average of those 3 trials of shoulder flexion to give me a more accurate assessment of that patient's true strength. So that would be the make test. So essentially just having that patient push into the handheld dynamometer as hard as they can. So now let's talk more about the break test. So the break test, the thing about this is it's going to require just a little bit more clinical skill in order to correctly utilize. And so with the break test, the goal is the clinician to push as hard as they can until that patient's arm, if we're talking about shoulder flexion still, would drop downwards. And then once that shoulder drops down and that patient is broken, you immediately stop pushing and it read the handheld dynamometer's force. And so with these 2 tests, with the handheld dynamometer, we're generating the maximal voluntary isometric contraction or the MVIC. And this is measured in either pounds, newtons, or kilogram force. And I think one thing that would be important to note here is on my appraisal of the literature, just kind of looking at the different research studies and how they conducted the different protocols, there's just a lot of inconsistency with methodology. So for an example, let's say one study gave a patient 1 minute rest in between those 3 trials, right? Whereas another study would give them a 3-minute rest in between trials. And some studies would only do 2 trials. Some studies would only do 3 trials. Some studies even did 1 trial. So there's just a lot of different methodology within the literature, but there was recommendation to use at least 2 trials per per muscle being tested to have the most accurate measure. So next, let's take a look at an example of how to actually use the make and break test.
All right, so we're gonna go over the two different ways you can use a handheld dynamometer. The first way would be using what they call as a make test. And so for the make test, you're gonna have the patient push as hard as they can, usually for 3 seconds into the handheld dynamometer. After those 3 seconds, you'll stop and then read that maximal force output. So we'll go over that right now. So Leo, what I'm gonna have you do is just hold this position. When I say go, you're gonna push as hard as you can for 3 seconds and then relax, okay? Ready, and go. Push, 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 and relax, good. So here we did it for about 4 seconds. We don't have the beep like the other handheld dynamometer, but we got a max force output of 32.8 pounds.
All right, so there's my demonstration of the make test, and the beep that I was referring to is in reference to the handheld dynamometer we have here at Scripps. And so that one, after 3 seconds, it'll have a beep, 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 and then that'll let you know that 3 seconds has passed, and you can stop the test or that trial, and then give that patient a break for the second or third trial. And I think it's also important to note it's something that I didn't really touch on in these two videos, but you want to allow that patient to incrementally increase that force output. And so what I mean by that is not having that patient push as hard as they can, 100%, right when you tell them to go. You want them to slowly, gradually build up to that maximum force output, just because that prevents that allows the clinician to stabilize the device more easy, and it gives you just a general better force output, because if that patient pushes extremely hard within that first second, there's a high chance that you're going to be pushed away. So that incremental push allows me to stabilize the device a little bit more accurate, and so I won't be moving as much when using the handheld dynamometer. Next, we'll take a look at the break test here.
Okay, now we're gonna do the break test. And for the break test, this is when the administrator is gonna push as hard as they can to break whatever position the patient is holding. Once the position is broken, then you're gonna immediately read that maximum force output. So for this, Leo, I'm gonna have you push as hard as you can. Once I move your arm a bit, then we're gonna stop and take that reading, okay? Ready, and go. Push, 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 push. Good. Go ahead and read that. So yeah, 52.9 pounds of pressure there. So typically speaking, the break test is going to have a higher output because of that eccentric contraction as you're having them.
Got cut off there. I was going to say, typically speaking, with the break test, we're going to see a higher maximum voluntary contraction, just because that muscle is now eccentrically contracting as you break them, as opposed to the make test. So that's just one thing to keep in mind, especially when we start looking at these normative values. All right, so looking at the pros and the cons of handheld dynamometry. Now, just because the handheld dynamometer is going to be more objective compared to manual muscle testing doesn't mean it's the end all be all. There's definitely some cons to the handheld dynamometer, but first we'll start off with the pros. So some good things about the dynamometer is it's going to give you more objective data like we talked about before. It's going to be a pretty portable device when compared to that gold standard, the isokinetic machine. It's a lot more affordable than the isokinetic machine. It's only $1,000. It's pretty simple to use. They've looked at studies just having graduate students use this, or just new graduates or new clinicians utilize the handheld dynamometer, and they're actually able to have a pretty high inter-rater and intra-rater reliability when compared to more experienced clinicians. So very easy to learn. It provides interval data, so that meaning that the difference between the force output is the same distance in measure. So 10 pounds of pressure versus 11 pounds of pressure is the same difference as 100 pounds of pressure compared to 101 pounds of pressure. So just the unit in which we're assessing is the same difference, is the same amount of change when adding or subtracting by one or whatever it be. So just a little bit more accurate in terms of comparing that to ordinal data going back to the manual muscle testing. And so another great thing about handheld dynamometry is they've actually looked at its reliability and validity in older adults, and it's been proven to be pretty good. So like generally speaking, the ICC of greater than 0.75, and then they've actually compared it the handheld dynamometer compared to the isokinetic gold standard machine, and it's pretty similar in terms of the true validity. So actually producing similar force outputs to that gold standard, which is great. And another great thing about the handheld dynamometer is it's more sensitive than manual muscle testing. So if we have a really strong patient and he feels pretty equal or she feels pretty equal on both sides, we can use that handheld dynamometer to see if there's any true asymmetry between sides and also give us a more accurate baseline as opposed to just saying that's a 5 out of 5 and that feels pretty strong. Now looking at some of the cons of the handheld dynamometry. So a lot of these were talked about in just the research studies looking at the dynamometer. And so first off, just being the positioning of the dynamometer. And so the handheld dynamometer requires a decent amount of strength by the tester in order to maintain the make and the break tests. And so that's what makes it a little bit more difficult when testing the lower extremity muscles, just because they're so strong. And there's just only so much we can do, especially if we just weigh less or we just don't have the strength to hold those positions. Another con would be the time consuming component of it. Obviously, just pushing down on someone's arm is going to be a lot faster than setting something up like this, especially if we're going to set up something with a gait belt, which we'll talk about in the future. But could be a little bit more time consuming compared to a quick MMT. The instability and discomfort of the handheld dynamometer is also another con. So being able to maintain that constant pressure and not to allow the dynamometer to slide or glide across whichever segment you're testing. So when Cody and I were using the handheld dynamometer on some patients, tibias in order to measure quadricep strength, we did run into some occurrences where the dynamometer would literally just slip off to the side. And so that could be that's definitely another con when using this device is you really have to make sure it's anchored down pretty good so it doesn't slip. And then another thing that we see pretty often is just the discomfort of that small surface area. Like if we look here in the bottom right with the Lafayette device, it's a very small surface area and you're having that patient push as hard as they can into that not so cushioned surface. And so it can definitely cause some discomfort. And as we know, with discomfort, we're not going to have a true measure of strength. Another thing about the handheld dynamometers is we don't really have a minimally clinically important difference. We do have minimal detectable changes, but from a clinical standpoint, we don't really know how much of a change is actually clinically important to that patient. And so that's something moving forward, maybe we can find within the next couple of years. And another thing is, the whole point of the handheld dynamometry is to measure maximal force output. And so understanding what is normal and what isn't, we don't have a ton of data to differentiate between typical and atypical values. But I did find some research studies that can help us at least give us something to look at. And then there's, like I said before, just a lot of variability in methodology. So the studies are all kind of different. Not a lot of homogeneity with the studies, and so there's just a lot of heterogeneous methods in which these clinicians and researchers decided to utilize the handheld dynamometry testing. And so specific to the handheld dynamometer, when we compare that to the isokinetic machine, because there are some limitations in terms of me as a clinician being able to be strong enough to push and the amount of discomfort or instability, we're going to have a lower reading of MVIC when compared to that more stable, with a better position isokinetic machine. So just know if we do use the handheld dynamometer, it's not going to be as high as an output when compared to that gold standard. So it underestimates true strength in patients. So now we're going to go over non-fixed positioning and normative values within different muscle testing positions. And so first off, we'll start off with shoulder flexion. And so this is going to be the general layout for the next upcoming slides. And so on the top right here, I have the limb position, the dynamometer placement, and then the stabilization. So here, as you can see, shoulder flexed to 90, elbow extended, and then the dynamometer placement is going to be just proximal to the epicondyles of the humerus, and the stabilization is going to be within the axillary region. And if we look here to the left below shoulder flexion, we can see that here is the normative values I was talking about. So with the normative values, we have both force in terms of pound, force in terms of newtons, and then force in terms of percentage. And it was pretty interesting because they actually did it percent body weight. So that meaning, like, let's say we took a look at that first line. So 50-year-olds to 59-year-olds male, N standing for non-dominant side, and we went all the way over to average force percent. So that means that for shoulder flexion, we would typically see around 31% body weight strength um, for the make test. And yeah, just to kind of preface with this manual muscle test, or sorry, with this handheld dynamometer test, and all of the future pictures and diagrams, these are all going to be specific to make tests. So all of these weren't actually break tests. And for whatever reason, I'm not really sure exactly why, but for all of these normative values that I'll be referencing here on the left side, it'll be specific to make tests. So that's just something to keep in mind here. And then I did also, so I have underneath these charts, if I was able to find any minimal detectable change within the literature, I went ahead and I put that here. So the minimal detectable change of shoulder flexion would be 4.5 kilograms of force. And so for this slide, I kind of went over everything in depth, but for these next slides, I'll kind of briefly go over what's on the picture just because that's kind of redundant in terms of exactly what I'm explaining here. So for shoulder extension here, we go ahead and place place the dynamometer just proximal to the epicondyles. And so really quick on the shoulder extension, I wanted to show, so that first picture on the top looking here, I hope you guys can see my mouse here. But this first chart is actually from one study. And then the second chart is from a totally different study sampling totally different patients. And so I thought it was super interesting that these normative values were so close between each other. And so like if we look at this first decade, so 50 to 59, and we went across and we said, okay, here, so a male non-dominant and dominant. So we see for shoulder extension, 302.6 newtons of force and 320.7 newtons of force. And so, okay, so then if we look down to this other study that did the same thing, so non-dominant, 303.4 newtons of force and 332.1 newtons of force. So that's actually a lot closer than I thought it would be. And I think if I'm remembering this right, the studies, the first and the second study, had at least 100 patients. So I know the sample size isn't massive; it's only 200 patients in total. But I just thought it was super interesting that these normative values are very, very similar between those two different studies. Here we have shoulder abduction. So you can see here my positioning's inferior to his arm. I think if I was to redo this, I would be superior to his arm. So I'm kind of, it's going to give me more leverage to resist his arm from elevating. So that would be one thing that I would change if I set this one up again. And so here we have the normative values and then the positioning at the top of the picture. So here we have lateral rotation. And another thing that would be important to notice is all these dynamometer tests are within a gravity limited position. And so that's one of the things that all the studies that I looked at stayed consistent with. And so that's why they have the patients in supine with all of these. And so the minimal detectable change with this one was a percent force, so that being 3.29% body weight. So if we were able to see an increase in that, that would be the actual minimal detectable change. And so here we have medial rotation, so the MDC a little bit lower at 0.78. So as you can see here, I'm stabilizing on the opposite side. So I think my positioning in this picture is a little bit better as I'm closer to the inferior side because I'd be resisting that direction of the wrist. And then another cool thing that I found, just generally speaking, in terms of minimal detectable change, was there's a study that specifically looked at MDC for the shoulder specific to handheld dynamometers. And if you wanted to take a closer look at all this, you can go ahead and feel free to pause this video here. But they looked at the intra-rater and inter-rater for all those different positions that we went over. But moving forward, now we're going to take a look at the elbow. And so here, I found personally the elbow is a lot easier to stabilize, just because you have the elbow being propped against the table, and then you can stabilize superior to the humerus. So I felt pretty confident that I would actually be able to do a good job of stabilizing and preventing just any sort of movement with the dynamometer as the patient's moving through the motion or resisting. And then here's our elbow extension. So just pretty straightforward in terms of the placement here. Right now, one thing to note is that I'm using a curved attachment, and the Lafayette device, I think right now it has, I think it's like 2 or 3 different attachments. So for the most part, I'm using the curved kind of C-shaped extension for this device that I have. It's a little bit different from the Lafayette, but still pretty similar. I think the one good thing about the MET device is that it has a flat end as opposed to the Lafayette, which is more rounded on the back end. Just makes it a little bit easier to fix against surfaces. But anyways, going back to the hip flexion. So as you can see, it's a gravity eliminated position here, and I couldn't find any minimal detectable change values for this. But this would be the positioning for this one. Here we have hip abduction. So I was able to find MDC for this one. So it was about 5.4% body weight change for males and 5.3% body weight for females. So pretty close, 5.4 or 5.3%. And then just stabilizing here on the contralateral pelvis. And then here we have knee flexion. So again, pretty straightforward, just hip and knee at 90, and then just stabilizing kind of just at the shoulders by the assistants. Yeah, so this is the one in which utilizing a fixed handheld dynamometer would be a lot better. And so that's something I'm going to be talking about in the upcoming slides. But I wasn't able to picture the assistant that was stabilizing my friend's shoulders here. So I was just stabilizing kind of at the quadricep and then holding the device just proximal to the malleoli. So this is when it gets hard to actually prevent any sort of movement during the isometric hold. So yeah, this is why it would be recommended to utilize something that would help you maintain that position, because it's very easily just to get moved around when you're trying to maintain someone's position with their legs. Here we have the knee extension. So yeah, for sure, this one is really hard to maintain. So with this, I was kind of propping my elbow up against my thigh and pushing inwards to oppose the force. So for the MDC on this one, it was 11.4 kilograms of force. And then for ankle dorsiflexion, but they did have an MDC on this one of 0.77 newtons per kilogram. And I'll go over in the next coming slides on the different stabilization techniques you can use for this one. So some considerations and limitations for handheld dynamometry. So there was the study kind of looked at all the different, a couple different testing positions for the lower extremity, and they found everything was pretty good in terms of the ICC here. As you can see, it's like 0.8, 0.82, so pretty reliable in terms of inter-rater reliability. But when they looked at specifically dorsiflexion, it didn't have that great of ICC. As you can see here, the inter-rater reliability, so looking at between clinicians, was pretty low compared to all the other testings. So as you can see here, it's only 0.48 as opposed. We're also looking here at the relationship between, so that was table 2 here, just looking at the reliability. And on table 3 here, we're looking at the validity. And so that being comparing the isokinetic $50,000 machine to the handheld dynamometer. And as we can see here, we have the Pearson R coefficient and then ICC values. And the Pearson R coefficient, I mean, isn't the greatest. It's decent. It's not excellent. So that's just something to keep in mind that, if we're going to be comparing the handheld dynamometer scores between uh between a gold standard, just know it's not going to be as high, and it may not be perfectly accurate, but at least the reliability of the measure is pretty close to itself. So handheld dynamometry within a handheld other handheld dynamometer assessments is pretty consistent. But when we do look at comparing it to the gold standard, it isn't perfect. And so we can see here the handheld dynamometer newtons. We can see here that specifically for left leg extension, right leg extension, the asterisk just annotating here, there's a significant difference between those measures. So we can see here the handheld dynamometer is pretty consistently measuring lower output. And that was kind of like what we talked about in those prior slides. Just the fact that you're not able to stabilize and that patient's not able to push as hard as they could without the device moving. So just for the lower extremity, it might not be the most accurate if you're not fixing it with a belt or some sort of stabilization technique. If you're just using your hand, it's gonna be hard to generate a true valid measurement. Another thing that people are criticizing in terms of handheld dynamometry is just the true amount of applicability and reliability of the measures. And so that last slide, we were looking at lower extremity specifically. In the systematic review, they looked at the shoulder, the elbow, and the wrist in terms of inter-rater reliability, and they kind of screened for bias within studies. And actually, they found a large majority of studies had bias just because they weren't, for one, stating who is the actual clinician administering the test, or it just had a very, very low sample size, or there's only one person administering the different positioning. So just hard to actually assess um, if it's accurate with a larger a larger clinician sample size. But they did find though, so they had their ICC cutoff pretty high at 0.9, and they said they wanted it at 0.9 because specifically they wanted to look at intra-rater reliability, so within the person. And they said, hey, if the handheld dynamometer is really good, it should be able to be reproduced within that same person pretty consistently. So they looked at prior research and their cutoffs were 0.75, and they said, hey, 0.75 is okay, but we want something better. We want to truly see that handheld dynamometer is accurate. So they bumped it up to 0.9, and they said, okay, shoulder, wrist, not so hot, only around like 0.6 to ranging to 0.9, but elbow was pretty consistently pretty reliable, greater than 0.9 across most of the studies. And they were able to find high quality studies without much bias for the elbow. So I think we can pretty confidently state that looking at elbow flexion and extension with a handheld dynamometer without any sort of anchoring device or stabilization belt, we can be pretty confident those measures are accurate and reliable, or sorry, only reliable, not necessarily valid. But one thing that the study did note was, hey, even though we're not getting 0.9 ICC, we're still using measures on a daily basis in the PT world that don't average out to an ICC of greater than 0.9. And so they said, hey, look, hip range of motion, cervical deep neck flexure tests, cranial cervical flexion tests, goniometry, tape measurements, all of those on average don't sum out to be greater than 0.9 intra-rater reliability. And so they said, well, on the other hand, handheld dynamometer is is okay because we still utilize all those other tests on a regular basis, but just not as reliable as they would want it to be. But one thing that they specifically noted was that they thought that in order to improve the overall reliability, what we could do is just add some sort of fixation. So as you can see here, to improve reliability, handheld dynamometer measurement likely needs external fixation as this will eliminate the influence of examiner strength. And so that's when we kind of look at this external fixation positioning. And so I kind of looked at some of the research that had been done on this. And so if we look at this study here on the left, reliability and validity of knee extensor strength, depending on its fixation. And so they said here that with the fixation, it showed a higher reliability than non-fixed handheld dynamometers, handheld dynamometry method by considering the intra-class, the ICC coefficient. And so looking at fixed, we can see it was 0.95 to 0.98, whereas non-fixed was 0.94 to 0.96, just a little bit more accurate. And that's only specific to knee extensor strength. And that was only a pilot study. It wasn't like a systematic review or a meta-analysis or anything like that. But just with this pilot study, they were able to prove that fixating the device created a higher reliability. And so moving forward, that could be something that we would want to implement in terms of creating more repeatable measures within ourselves. And so another thing that they found was not only does the stabilization or external fixation of handheld dynamometers allow for more reliable tests, but you can also rig the device to create a cushion of some sort to prevent the pain being the limiting factor in terms of measuring total force output. And so here you can see here on the bottom right, they put a pad and then they anchored the dynamometer below the bedpost or the table post. And so that allowed the patient to push into something soft as opposed to something extremely rigid like that small surface area of the circle for that force platform. And so here I was actually able to find recommended shoulder fixation positions using a handheld dynamometer with a belt. And so with shoulder flexion, they would just anchor the belt and kind of hook it underneath the bedpost. So for the high-low tables that we have, just anchoring it at that bottom horizontal bar there, and then just fitting that handheld dynamometer in between the belt in contact with the arm. And so that would be how they would set up. Let's see here. So they did that for flexion, they did that for abduction, they did that for horizontal extension. But in terms of shoulder extension, external rotation, and internal rotation, they mentioned the stairs baluster parallel to forearm. And so essentially they were hooking it through a stairway with the vertical frame. And so they would anchor that there, and then they would they would get the belt pretty taut. And so it wasn't like the patient was extremely far from the anchor point. They would get them pretty close to that wall. And then they sandwiched a 5 kilogram bag of sand so that they weren't pushing into something that would flop around, just like pushing into that hard railing. Give them something hard to push into, just so that it wouldn't be extremely wobbly. And so I thought that was pretty smart. I did come across some other studies that instead of necessarily using a stairs baluster, they used um, they used kind of these the horizontal dowels, just like that. That's this picture here, and so they would just hook the belt around there, parallel to whatever height that that person was either standing or sitting at, and then fit the handheld dynamometer in between the belt and then against their arm. And so that would be another way of anchoring it. Um, but in terms of anchoring it somewhere at the clinic that we have, it'd be interesting to see if we would be able to replicate this. I'm not actually sure if we have something similar to this stretching wall here, that wooden wall. But it would be something that we could consider just anchoring to. I also thought of if we were able to raise the tilt table to its highest position and then have the patient sitting and then anchor it from there so that the top horizontal post would be most likely parallel to the height of that patient's forearm so that we can get an accurate assessment without utilizing the stairs or that stretching frame there. And then here would be a shoulder abduction. So not the perfect picture. I try to get a good picture with this one, but essentially what all we're going to do is, instead of utilizing that suction device there on the bottom, we're just going to loop it underneath that bottom rail and then position the arm in abduction. And then here would be the positioning for shoulder external rotation and internal rotation. So just finding a way to anchor it parallel to that person's forearm. So here you can see they anchored it with this wall device here, like this suction device that they had been using, and then fitting that device in between their arm and the belt. And then I thought it was pretty interesting that so some studies have been using like they could create like they make their own PVC pipe and then they fit it on the flat end of the MET dynamometer, and that's not necessarily, I don't know if that's something that we can necessarily do with the rounded edge of the Lafayette dynamometer. But this is just another way that they used to resist the external and internal rotation positioning. I also think it would be possible to position yourself against the wall, and then now the patient can't push you because you're just going to push yourself into the wall. So just you can also try all that and see how that feels in terms of stability. So like let's say in this picture here, instead of using this PVC pipe, um, you would just be standing with your back against the wall and that patient's chair just right up next to you, so that you're leaning against the wall, you're already pressed up against it, and then that patient's just pushing into the dynamometer as you're stabilizing it. So not much room for you to move. So I would imagine that to be pretty stable. So here, this would be the fixed knee flexion. And so there's actually an MDC for this fixed knee flexion positioning. So it's about 18.6 newtons for males and then 22.3 newtons for females. And so here we're using that bottom horizontal railing on a tilt table here in one of our laboratories at SDSU, and just anchoring that handle dynamometer in between. And then here we have a hip abduction fixation. So on the picture here on the left, they just use a standard hip abduction position with a stabilization or a gait belt looped all the way underneath the table. You could see that better visualized here on the right. And so here on the right, they used stabilization for the trunk superior to the pelvis, and then they fitted the dynamometer in between the mobilization belt and the patient's distal lateral femur. Here we have hip extension. So with these, I don't really have normative values. That's one thing to note, just because there were no normative values for these fixed positionings, whereas the non-fixed positioning where you're maintaining the stabilization, I was able to find those reference norms, which were mentioned previously, but that's why you're not seeing any normative values with these pictures here. But I was able to find MDC for hip extension that was stabilized at 14.8 newtons. And that was just generally speaking for males. All right, so here we have hip external rotation. So as you can see here, they're positioning the mobilization belt just lateral to that patient's femur or tibia. And then they're positioning that belt right in between, or that dynamometer right in between the belt there. That'd be a way to fixate that. And then here we have fixed knee extension. So here you can see the picture of me lining up my friend's knee to just measure specifically at 60 degrees of knee flexion, and then positioning the handheld dynamometer so that it's fixating with his knee at that position. And so the 60 degrees of knee flexion, knee flexion is specific to just some of the ACL return to sports studies, and they're looking at maximal knee extension torque within this 60-degree positioning. But it's totally fine to do this at 90 degrees. And I think it'd be more comfortable if you're able to anchor the dynamometer behind the patient's leg, so that you're able to find a soft surface to put at the tibia or the shin, just to make this a little bit more comfortable. So that's one of the cons of doing it at 60 degrees. So going to 90 degrees would be totally fine too. And then the MDC with this would be 2.2 kilograms of force. And then here we have that fixed ankle dorsiflexion. So just hooking this around my own waist, kind of like when we're mobilizing patients with the belts. And so that would just be a way to anchor this one and provide more stability. Here we have fixed ankle plantar flexion. With the dorsiflexion and plantar flexion, I could not find any MDCs specific to fixed handheld dynamometry. But just know If someone's coming in with some ankle pain or plantar fasciitis or Achilles tendonitis, this could be a way of measuring between sides if they do present pretty strong um, bilaterally. So big question is there a better fixed option? It seemed like most of the reliability studies in reference to handheld dynamometers seem to suggest a lack of stability or a lack of fixation. And so those few slides that we went over discuss the different options and positionings for fixation. But this new study that came out in 2021 looked at the intra-rater and inter-rater reliability using a pull handheld dynamometer. So this is that crane. So going back, so if we look at this bottom left picture here, going back to that suitcase dynamometer where it's tensioning as opposed to pushing. So that they looked at the tensioning devices compared to the handheld dynamometers. And so as you can see here in the two pictures on the bottom left here, um, here is all the positioning for the crane dynamometer. And it was pretty interesting to see how they just utilized their own body weight as a way to fixate the crane. And so I don't know necessarily if this would be extremely accurate in terms of measuring knee torque, but I think for upper extremity, it would be totally fine. Seems like the wrist strap here would be a pretty stable way of measuring that force without it moving so much. And then here on the right here, we have the comparison of the handheld dynamometer positioning. And then they charted the reliability differences. So the the pull being the crane device, and then the push being the microfet handheld dynamometer. Um, so we can see here the pull, the distribution of the yellow dots is a lot smaller than the push handheld dynamometer. So just the red dots just being a lot more spread out consistently between the top chart and the bottom chart. So the bottom chart being female patients and the top chart being male patients. But I also think it's important to recognize that when they were looking at the dynamometer positioning for the microfet, they were doing it in a non-fixed position. So maybe utilizing a belt or an external fixation device, we would see similar results to using the crane device. But I think in terms of setup, that crane device does look like it's a little bit easier to stabilize without having to flop around and get the belt at that specific tightening point. But yeah, just another thing to consider in terms of um, dynamometry options. So a couple of takeaways. So handheld dynamometers are an objective way of measuring force. Handheld dynamometry is a valid and reliable tool, and handheld dynamometry's reliability can be improved with fixation and comfort. But at the end of the day, if you do decide to use handheld dynamometry and decide to use reference norms, one thing that they did consider or did say to take into consideration was if you're going to consider anyone weak or impaired, they must be at least 2 standard deviations below the normative values. But I think it's just important to know at the end of the day, the most relevant normative value for a patient, for a specific muscle group, is going to be that own patient's value on their baseline assessment. And so not necessarily sticking to and always referencing normative values, just knowing that handheld dynamometry can give us a good value and a good reading of that patient's baseline so that we can track that strength change in the future. Thank you guys all for listening. Here are my references. Thank you all for watching.